All right. Awesome. All right. Well, welcome everybody. This is to the first uh, section pediatric neurosurgery webinar of the academic year. The topic today will be an overview and discussion of craniosynostosis, and we're very lucky to have Dr. Amy Lee leading our initial didactic session. She is the Chief of Pediatric Neurosurgery at Seattle Children's, our friendly neighbors to the north, as well as our Fellowship Director, Residency Program Associate Director, and Director of many of the pediatric subspecialty programs that involve neurosurgery up at Seattle Children's. I can go on for quite a while, but I know that Dr. Lee has a lot to say, so I will let her get into her talk. Thank you, Amy.
Well, thank you, Jesse. And I want to thank Susan and, Doctors Durham, Leonard, Limbrick for inviting me to speak today. And so I was told this is an audience of fellows and hopefully residents who want to go into pediatric neurosurgery. I have to say that I'm a little nervous that actually my mentor, Matt Smith, is on this call because, he's the one who introduced me to all this and taught me everything I know. So Matt, you could tell me if I do a good job or not when we're done. So let's see. I am actually trying to maneuver my laptop and desktop because I'm having. So anyway, I know we'd say thanks at the end, but I'm going to start at the beginning by thanking Dr. Sinu Susarla. And he's actually one of my craniofacial plastic surgery colleagues. And the reason I want to thank him up front is that as neurosurgeons in these cases, we don't usually take pictures, but our plastic surgeons do. And so if you want to have nice pictures for your talks, you got to hit up your plastic surgeon. So a lot of the interop and some of the photos at the very end are ones that he has shared with me, are cases that we've done. So I want to give him some thanks up front. And actually, I think there may be a couple slides that I've borrowed from Matt as well. So anyway, just to get started. So I usually like to start off just talking about normal and then moving to abnormal. So this is just a slide showing the normal skull of the newborn and all the open sutures. So the major sutures of the newborn skull are composed of like fibrous connective tissue, which responds to, a variety of complex, like incompletely understood ways of kind of dealing with like intrinsic and extrinsic factors like the underlying brain growth and the underlying dura. So it's actually the brain that dictates the growth of the skull. So the brain reaches about 75% of its ultimate volume by the age of 2. And so we know that this is actually a period of rapid and sensitive growth. And so this is just actually a slide showing at the time of normal suture closure. So you could see that besides the metopic suture, which closes between 2 months to 2 years, all the other sutures actually close well into adulthood. So some of you on this Zoom are probably still young enough to have your sutures still open, but unfortunately for me, and I'm looking at Susan, sorry, no such luck for us. So what is craniosynostosis? So craniosynostosis is premature closure of one or more sutures of the cranial vault. So early fusion of cranial sutures will generally cause abnormal growth of cranial vault and skull base, and it may affect brain growth and development. So in a little bit, we'll talk about most common non-syndromic types, which have an incidence of 1 in 2,500, and then the rare, and a little bit about the rare syndromic types, which are less than 1 in 25,000. So this is just a slide that just demonstrates how we classify craniosynostosis, defining whether there's non-syndromic versus syndromic type, how many sutures are involved, is it single, is it multiple, and then other things like to consider like major sutures versus minor sutures. So I'm giving credit where credit is due. This is a Matt Smith slide that I borrowed from him. But just for a historical perspective, physicians as far back as Galen and Hippocrates recognized the relationships of the cranial sutures to skull shape. So by the 16th century, anatomists had described a wide range of cranial abnormalities associated with premature fusion of a suture. And so as people continue to expand on the idea of others, Virchow in 1851 first described characteristic abnormal growth patterns with specific synostoses. And then he classified them morphological descriptions that we still use today. So the premise that normal skull growth tends to be in a plane perpendicular to the suture and abnormal growth is parallel to the fused suture is generally called Virchow's law. And so why do they fuse? Well, we don't really know. So we know that there are genetic factors for the syndromic cases and other factors that are listed here below. But as our understanding has progressed, we've learned that the relationship between the sutures and the skull growth is actually not as straightforward or linear as we originally thought. So in 1959, Moss was the first to appreciate the effect of the actual skull base on the cranial vault, and he proposed that the primary mechanisms that were driving the cranial deformity came from the skull base and actually not the suture. So he actually noted that removing the suture didn't always change the skull growth, and this observation actually contributed to developing more complex surgical procedures than just simple strip craniectomy. So the theories of Moss, in combination with the pioneering work of Tessier in the 1970s, led to the extensive cranial vault reconstruction procedures that we use to correct synostosis today. So again, as I said earlier, we don't really completely understand why this happens. There are complex interactions between bone, the pericranium, and the dura, but we do know that head shape differences result because of the abnormal fusion. And so for non-syndromic cases, most appear to be sporadic. Again, this is likely a combination of genetic factors and external forces that mediate the pathway to suture fusion. More than 100 mutations have been identified, and autosomal dominant inheritance is actually noted in about 10% of cases. So coronal and pneumotopic synostosis is more likely to be familial than compared to sagittal. Let's see. Syndromic synostosis is usually associated with additional anomalies outside of the skull, like mid-face hypoplasia, which is the most common. And it's more likely to involve multiple sutures. And in fact, over 150 craniosynostosis syndromes have been described. Primarily, they're autosomal dominant in inheritance, and majority are related to FGFR genes. And so how do we diagnose craniosynostosis? Well, really, mostly what you need is a good clinical exam. That's all that's necessary. So it's easier to make this diagnosis 2 to 3 months postpartum when the infants, because earlier on the infants can often have a misshapen head. But aside from other information like family history, prenatal history, the physical exam is really the most important part, where you need to make note of such things like the head circumference, the cranial shape, orbital deformities, facial asymmetries, and things like that. And so these are just some common imaging modalities, and I've included, this is just for completeness sake, but really the 3D CT has become the standard for us to determine whether there's a patent suture or not. And again, you can pretty much know if you've done this long enough to see the type of synostosis they have just in the clinic by looking at them. But for those mild cases, it really comes in handy, and also to differentiate between deformational plagiocephaly and lambdoid synostosis. So when we talk about clinical presentation, so here's an example of unicoronal synostosis, where you can notice here, I don't know if you see my pointer, but just this anterior plagiocephaly as opposed to the posterior plagiocephaly that you see in lambdoid synostosis, which can be distinguished from positional plagiocephaly, where there is no mastoid bulge or a skull base tilt. So non-syndromic craniosynostosis is typically diagnosed postnatally just by observation of these very characteristic skull shapes that you see. So as I mentioned, you can use a CT to confirm the diagnosis in mild cases, but again, just a good physical exam, you should be able to distinguish which synostosis it is. So if you look here, here's going from metopic, sagittal to lambdoid, you see the typical characteristics like the trigonocephaly, this triangular shape. Scaphocephaly, this long, elongated kind of boat shape, or I like to say from the side, they look like little toaster heads. Lambdoid, posterior plagiocephaly, bicoronal, you see brachycephaly, and then unicoronal, they've got this anterior plagiocephaly here. So the two main indications for surgical treatment for craniosynostosis are, one, to correct the shape of the skull shape for aesthetic and psychosocial considerations, and also to make certain that there is adequate space for normal brain growth. So for from an aesthetic perspective, the deformities associated with craniosynostosis are generally progressive for the first year of life. And although the risk kind of varies depending on the specific diagnosis, a small but pretty significant percentage, anywhere from 4 to 14% of patients with single suture craniosynostosis can develop intracranial hypertension. And so and as the incidence is as high as 47 to 60%, 67% in patients with multiple sutures that are involved. So if you consider kind of the risk-benefit ratio, because we actually don't know which patients are going to develop elevated ICP, we offer surgery to all children who present with craniosynostosis. If you think about the risk of them getting elevated ICP versus the very, very, very low, less than 1% risk that anything catastrophic can happen, it's clear that all children should be offered surgery. And so what are our treatment goals? Well, if you don't treat craniosynostosis, we know that it can cause elevated intracranial pressure. If we leave them untreated, they can develop consequences like chronic headaches, developmental delays, and vision loss. But also it's important to recognize that the social and psychological impact on these children can be sufficiently concerning just to justify treatment too. And so the treatment actually involves surgery to make sufficient room for the brain growth, as we've described, and to normalize the skull shape. And intervention early in life has the advantage of utilizing the effects of the rapidly growing brain to reshape the skull, and along with halting those secondary deformities in the face, the skull base, and the cranial bulb that can occur that first year of life. And so this is just kind of a diagram, you want to make sure that we're balancing the age for anesthetic risks versus favorable growth potential, persistent cranial defects that can occur if we do surgery later. Generally, the procedures in young infants tend to be less invasive, but there is increased surgical risk in the smaller infants because there's obviously a greater impact if they have even a little bit of blood loss can be significant for them. So this is where I can't stress the importance of a really skilled team. You have to have anesthesiologists who understand the complexity of these cases. I mean, this can't be overstated. So, our center actually wrote a paper on this. I mean, craniosynostosis procedures are generally quite safe and with overall low morbidity and mortality rates, but, they can really go sideways quickly if you don't have an experienced team. And so at Seattle Children's Hospital, we actually do a lot of, protocolized clinical, what we call CSW or clinical standard work. And these are just some pathways that were developed by our team. It really just kind of takes the patient through their, quote unquote journey through the process. And I'm just going to go through this quickly, but this is just the algorithm we follow for the diagnostic phase. We've got, the same for the pre-surgical phase. Even something that we do like in the holding area before they go to surgery. And then of course, after surgery, there's the transfer phase, the ICU, and then the discharge phase. So this is just kind of the protocol that we follow and develop. And I think it streamlines just the care of these patients so everybody knows exactly what to do. And so, of course, as I mentioned, multidisciplinary team, I can't stress that enough. And I couldn't do any of this work without my amazing colleagues here at Seattle Children's. So going from left to right, Craig Berkfeld, Richard Hopper, Sinusa Sarla are my awesome craniofacial plastic surgeons that I work with. And of course, my neurosurgery partner in crime, Dr. Rich Ellenbogen. And so now we're just going to jump right into the meat of things. And so going from the most common synostosis that we see, sagittal synostosis. So you can see these pictures here. These are very classic features of scaphocephaly. You can see the elongated anterior posterior head. They've got frontal bossing, an occipital bullet, and this narrow biparietal width. And this is, again, the most common thing that we see at Seattle Children's with an incidence of 1 in 2,500. And so those fancy 3D CTs I talked about here, again, you can see that there is premature fusion of the sagittal suture here. You see that elongated head shape, that occipital bullet, and the frontal bossing. I think reported in the literature, you see craniosynostosis actually being the second most common, but at Seattle Children's, we actually see 30% of our patients we see are actually metopic. So here's the trigonocephaly head shape, this triangular forehead. They've got bitemporal narrowing, hypotelarism. And again, this is 1 in 10,000 patients that we see. Again, the fancy 3D CTs with that trigonocephaly or triangular head shape. And you can see the fusion of the metopic suture. So moving on to unicoronal synostosis, this patient, you can see anterior plagiocephaly. They have ipsilateral forehead retrusion. They can plus or minus contralateral forehead bossing. Sorry, ipsilateral forehead protrusion, anterior superior displacement of the ipsilateral ear. I don't know that you can see that very well on that bottom picture. The nasal radix is deviated to the affected side. They've got a retruded supraorbital rim and brow with this harlequin deformity, which we'll see better on the next slide. And this is 5 to 10% of what we see at Seattle Children's. And so again, here's that fancy 3D CT. You can see that harlequin deformity here and that fused suture right here. Bicoronal synostosis, they've got this turry brachycephalic head shape, or this kind of flat but like tower head, bilateral retruded forehead, and supraorbital rims, increased biparietal diameter, and the incidence of this is variable. So again, here on these CTs, we see this fusion of the coronal sutures bilaterally. Moving on to lambdoid synostosis. So posterior plagiocephaly is seen, ipsilateral, they have this ipsilateral occipital flattening, this mastoid bulge on that ipsilateral side. The ipsilateral ear may be posterior and inferior, and the head's more trapezoidal shape, and they have this skull base tilt, which you will see better in these 3D image here. So here's the fused lambdoid suture, mastoid bulge with that skull base tilt. Oops. And again, just differentiating lambdoid synostosis versus positional molding. They've got this trapezoidal head shape versus the parallelogram that you see here, with the mastoid bulge and that mastoid bulge with the skull base tilt. So now we're just going to go into treatment. Starting first with sagittal synostosis. At our institution, we offer, just like most places, we don't actually do springs. We only offer endoscopic strip craniectomy. Sorry that typo is there. That's actually now driving me nuts that I see that, but versus the open cranial ball expansion, we typically offer the strip craniectomy for children ages 4 months or younger. And then the open can range anywhere from 3 to 8 months. It says 4 to 7 months there, but there's really a wide range there that we can do those surgeries. I've got Matt Smith on this Zoom with us. I mean, he's definitely taught me a lot about how he used the one that taught me how to do these procedures. I brought this technique to Seattle Children's when I came here 12 years ago. And obviously everybody kind of knows the debate between these two procedures. You've got the pros and cons of both, shorter operative time, less time in the hospital, but you do have to do the molding for up to a year. But then the open procedure obviously is like a one and done. Yes, there's blood loss. Yes, you need a transfusion, but you don't need to do any helmeting therapy afterwards. So there's really advantages or disadvantages to both. I'd say that at our institution, we probably do a fair number of more of the open ball procedure. And I say that because our catchment area is actually the WWAMI region. So we cover a 5-state region. So I think it's really hard for a lot of patients who are coming from Alaska, Montana, and Idaho to find a proper helmeting center to actually choose the endoscopic route, even though we offer both. And so I'd say a fair number of our patients actually go the open route. And so these again, thank you to Sinu for these great intraoperative photos of our patients. You can see our traditional kind of coronal, zigzag coronal incision that we do. This is the skull. You can see that fused suture. And then this is the mark craniotomies. So this is the modified pie procedure that we're doing here. And these are I just go in and I got to make sure that I stay on the line, right? For all of us who do synostosis surgery, make sure we stay on the line. And here we go after the cuts are made and then the reshaping's done. So now they've gone from toaster to nice round bowling ball. So everything looks really good and we've opened things up. So again, this is post-op. You could see already a difference in their head shape. And this is just a nice 3D before and after photo from those nice 3D CTs that we get post-op. And then here are the results. You've got the preoperative photos with that long elongated skull shape and the frontal bossing, the occipital bullet, and this is the same child 3 years post-op. Looks pretty good. So for the endoscopic procedure, we actually still do the wide vertex, craniectomy with the wedge osteotomies or barrel staves. This is the way I learned from Matt. I know he doesn't use this technique anymore, but we still do this. I can't get my plastic surgeons to change it, but this is what we do. We actually morselize the bone and actually put it back in to the defect. And then I don't know where that squiggly line came from, but this is pre-op pictures here, and then that same patient post-op, 1.5 years post-op. So frontal orbital advancement, this is actually the standard treatment for metopic, unilateral, and bicoronal synostosis at Seattle Children's. So again, we use the coronal incision, we expose the forehead and 2/3 over the orbit, and we perform our craniotomies, osteotomies, and then we do the reshaping. So again, this is a child that you can see here this is just pre-op, marking out the zigzag incision, marking out just the craniotomy right here. You can see the cuts that we're about to make. This is after the orbital bandeau is removed, and then you can see the reshaping that's been done. It's nice, moving from that triangular shape and then putting it back in, and you can see that expansion that we've done. And then this is after we put everything back. And again, triangle to circle. Looks pretty good. And again, this is that same child pre-op and then 2 years post-op. And then looking at the 3D CT, we can see the pre-op, intra-op, and then the 2-year post-op, where you can see the bone healing that's occurred. Same, just kind of aerial view of the same patient. Pre-op, post-op, or immediately post-op, and then 2 years post-op. These are just skull-based views, the expansion that we've done. So similarly, this is unicoronal synostosis. We've got the exposure marking the craniotomy here, focusing on the affected side. And this is after the bones are removed and after their kind of the remodeling has been done, and then putting the orbital bandeau back in. Again, once everything's put back in place, pre-op, post-op. And again, nice photos of the pre-op images and then 2 years post-op. Showing the same thing. We got pre-op, immediately post-op. And I thought we had some 2-year post-op, but I guess we don't. So lambdoid synostosis. So we actually do offer endoscopic for this if they present early enough. But this is just kind of showing the results after a switch cranioplasty that we've done. So this is just kind of looking at the line of when we've actually taken those pieces and switched them and put it in the opposite order that we took them out. So here you can see that mastoid bulge, the fused suture, And then the post-op image is nice and round. So despite the fact that we do this, though, you're not going to actually fix the skull base tilt or the mastoid bulge, but we can definitely round out the head shape. Again, this is just pre-op, post-op images. So that's just kind of the general overview of all the major suture synostoses, the single sutures that we see. I'm just going to touch briefly on some of the syndromic ones, and then I think we're going to go into our case discussions shortly thereafter. So the diagnosis and treatment of craniofacial syndromes are actually, in my mind, some of the most complex problems that we encounter in pediatric neurosurgery. The craniofacial syndromes are a heterogeneous group of conditions where premature suture closure, often multiple sutures, occurs alongside manifestations like skeletal abnormalities, and in particular, those of the hands and feet. So these children exhibit progressive synostosis of multiple sutures, including synchondroses and sutures of the skull and the skull base. And so they often have premature fusion of the suture of the orbit and also the maxillary bones. So the conditions that we most frequently see are the eponymous like syndromes like Cruzons, Aperts, Pfeiffers, Say-3-Chosin, monkeys. Less commonly, Antley, Bixler, Jackson-Weiss, some of the more rare ones. But the aim is actually really to ensure that we can realize like what the child's full developmental potential is. And so that's why early intervention for these children is really key. And so this is where, again, I emphasize the importance. I know this is a busy slide of a multidisciplinary team, because these patients are not only taken care of by craniofacial plastic surgeons and neurosurgeons, but you've got a team with pediatricians, orthodontists, pediatric dentists, speech pathologists, otolaryngologists, audiologists, ophthalmologists, genetic counseling, the nurse coordinator, social worker, psychiatrist. So it's really important that, a multidisciplinary team is involved when we take care of these patients. So just real quickly, Cruzon syndrome, this was first described by Cruzon in 1912. It's associated with the FGFR2 gene. It's a autosomal dominant or sporadic inheritance pattern. And the pretty classic phenotypic features are brachycephaly. They have shallow orbits with ocular proptosis. They have a constricted high arch palate, a mid-face hypoplasia. They don't typically have any other associated anomalies with it. But sometimes we do see Chiari malformations, platyvasia, due to the skull base abnormalities and hydrocephalus. Next is Apert syndrome. This was described by Apert in 1906. Again, the FGFR2 gene, autosomal dominant, possible, mostly sporadic, but you can see they have this like classic Turi brachycephalic head shape. Their anterior fontanelles are usually large and open, and they've got some bitemporal widening and this occipital flattening and shallow orbits with ocular proptosis. They have symmetric syndactyly of both their hands and feet, and often involving fusion of the second, third, and fourth fingers and/or their toes. And again, we can also see Chiari malformations, platyvasia, hydrocephalus with these patients as well. So the last I'm going to talk about is Pfeiffer syndrome. So in 1964, Pfeiffer described a syndrome of craniosynostosis with like broad thumbs and great toes with partial tissue syndactyly of the hands and joints. But recently, the syndrome severity has actually proven to be very variable. So there's 3 types listed here. Type 1, the classic Pfeiffer syndrome. Type 2 is associated with cleavage shadle, which is like the clover leaf deformity. They have severe ocular proptosis. And then type 3, where they have severe ocular proptosis, shallow orbits, marked shortness of the anterior cranial base. They don't have that clover leaf deformity. But these children usually have associated broad thumbs, broad great toes, and actually some pretty severe CNS involvement, with like hydrocephalus and like in type 2. And so this is again 3D CT with 3D CT with a Pfeiffer patient with a cloverleaf deformity. And these particular cases are very challenging, that you can see all this kind of like Swiss cheese, skull, that you have really thin dura kind of invaginating through these little defects. And so when you're trying to take the bone off, it's easy to get a CSF leak and dural tear because the dura is so thin, and it's some of the more challenging craniofacial cases that we do. And so, and why do we get involved as neurosurgeons? Well, elevated ICP is a very well-recognized complication of syndromic craniosynostosis. As we talked about, the more sutures you have to use, the high likelihood of elevated ICP. So the underlying pathologic mechanism responsible for elevated ICP is likely multifactorial, but it could include cephalocranial disproportion, venous outflow obstruction because of the skull base abnormalities, upper airway obstruction, again, due to those skull base abnormalities or mid-face anomalies, hydrocephalus, narrowing of the cranial foramina. So intracranial hypertension can develop gradually, but it should be pretty evident. And so remember, these kids actually have very shallow orbits, and they can present with severe orbital proptosis. So it's really essential that we protect their orbits. And so this may actually differ among different institutions, but this is a typical framework that we follow at Seattle Children's, and that is that at birth, if they have severe or definite concerns for elevated ICP, we may intervene earlier than this, but typically between the 3 to 6 month range, we perform a posterior cranial vault distraction, and then just let them grow, and then eventually they may fall into one of these categories that for surgery in the future. And again, this next slide is really just kind of describing that again. These are often procedures more that the craniofacial plastic surgeons performed, and sometimes with our assistants. But that's really kind of all I have for the syndromic, because I wanted to focus more on the more common things that we do. So that's really it for now. But I just want to take a moment to actually thank my mentors, because I know that there are mostly fellows and residents on this call, and I can't emphasize enough that during your fellowship especially, you're going to be developing relationships with those faculty that you work with, who are going to be your lifelong friends and mentors. And so there are people on this slide like Matt Smith, who again, as far as everything I learned about craniosynostosis was from him. He's on this call. And Jeff Leonard, you've got T.S. Park, Ralph Dacey, my chairman, and Dave Limbrick. So these were my inspirations for going into pediatric neurosurgery way back in the day when I was a resident and fellow. And then of course my UW team here with all my partners, who are all amazing teammates of mine and my second family here. So again, thank you for this opportunity. And I guess we're going to go into the case presentations.
Thanks, Amy. That was amazing. A really awesome overview. So what we'll transition into now is we have 3 different case presentations. We're going to start with Kelsey Hundley, who is our fellow here at Dornbecker Children's Hospital, OHSU. I'll have each presenter kind of go through their presentation, and then I'm going to open it up to the field for comments and discussion. And if I don't get any hand raises or initial discussion, I will call on some people, especially names that I recognize and or can pronounce. So Kelsey, why don't you go ahead with our first case?
Okay, thanks for having me. I want to talk about the benefits and pitfalls of endoscopic release. Let's see. All right, so our patient today is a 2-month-old male who was referred to clinic by their PCP for an abnormal head shape. As you can see, he's obviously scaphocephalic, and a diagnosis of sagittal synostosis is confirmed on reconstruction imaging. We discussed with his family the diagnosis and options for repair, including open and endoscopic techniques. But the family's very nervous. He's 2 months old. They just want to get things done, get it over with. They don't want to wait, and they decide to pursue endoscopic options. We went through the procedure in detail together for strip craniectomy, and including the need for helmet therapy afterward. But this made them very nervous. They're from rural Oregon, and they were concerned that there may not be an orthotist near them who could help them. or anyone be available to do like the laser imaging for helmets. We said that's okay. We do offer springs, but the drawback is that they will have to come back in a few months for removal. They really didn't like hearing that. And after a little bit of research, they realized there wasn't orthotists they felt that was near enough to them with some experience that they could be compliant with. And so about a month later, our patient comes to surgery. Here he is prone in a Doro head holder. We planned our 3mm incisions anterior posteriorly, and a strip craniectomy was carried out. Surgery went great. Blood loss was minimal. It lasted a few hours, and the patient was able to go home the next day. To recap some of the benefits we discussed, the surgery was shorter, the incision was smaller, there was decreased blood loss and length of stay, and our colleagues in plastic surgery did not need to join us. On the other hand, there's evidence that the revision doing this, like for metopic and coronal synostosis, isn't great. They have higher revision rates. It's better for sagittal and lambdoid synostosis. People in rural areas everywhere, really, but especially rural places like Oregon. We talked about Alaska, Montana, Arkansas, where Scott Boop and I came from. It's really hard to find someone to do these helmeting services in such a rural area. And while springs can be an option, they do require removal surgery, and not every parent is amenable to bringing their kid back. But as for our patient, the family was compliant with helmeting for approximately 9 months, and he's doing great today with a normal head shape. Thank you.
Thank you, Kelsey. So thoughts, I'm actually particularly interested to hear from fellows in other parts of the country, this decision for endoscopic versus with helmets and springs and how that plays into your different practices.
Jesse, I'll jump in since nobody else is
Matt.
talking. So I have zero experience with springs. I started doing the minimally invasive strip craniectomy with helmet therapy about 17 years ago or so, 18 years ago, when Jimenez and Brony started talking about it. And yeah, the access to the orthotist is important. When I was in St. Louis, we'd have families that were often 3 or 4 hours away from a big city, but we kind of created a network of orthotists that could help out. So that wasn't a big problem. Up in the Pacific Northwest, like you're talking about, I see how that's a big impediment. Kelsey, I was curious about your slide talking about coronal metopic revision rates being higher with minimally invasive. So that hasn't been our experience. We've looked at our revision rates for minimally invasives for coronal and metopic, and it's similar to revision for open surgery. So I know Seattle, you guys don't do that pretty much at all, right, Amy? For coronal or metopic, you only do open?
Yeah, we only do open. I mean, like as I mentioned, we do it for lambdoid, but we don't do it for coronal. I mean, we've actually done maybe a couple metopic just because they came to us. I think one of the patients came from Hawaii, but I just our group just doesn't feel like we get as good as results as what's published out there.
Yeah, I mean, it's just really important to have a good orthotic partner who can really make sure. I mean, if you don't have a good experienced orthotist, you're not going to get good results. So there definitely is a learning curve there. And you probably shouldn't be doing it if you weren't with an orthotist who is experienced. I also found it interesting the comment that plastic surgery didn't need to be there. And in terms of program building and team building, that's kind of, there's some friction there if you're doing these cases without your plastic surgery colleagues. So I was always aligned with our plastic surgeons in every single case. We did them as co-surgeons. I initially worked with Alex Kane and then Albert Wu and then Cam Patel. So even on the minimally invasive ones, we still found a way to have everybody have a role in the case and feel needed and wanted and participate.
Yeah, I agree with you, Matt. We've done similarly the same here. That I think there's parts that obviously are important to us and the safety aspect of it, but they do the scalp, the subgaleal dissection. Then I do the cuts, and usually because we still do those barrel staves on the sides, I actually just hold a retractor for them while they make those cuts so that we can all be contributing to it together. So I agree with you.
Yeah,
Amy, I saw you were putting that mortualized bone graft in the defect. That's kind of a nice idea for the minimally invasives, but was that because you had a high rate of defects initially, or?
Oh, we've been doing that from the very beginning. I think when, again, as I mentioned earlier, like I learned this from you, and then I came here and they weren't doing any endoscopic. And so I brought that technique, and I think they felt really uncomfortable leaving such a large defect and so even from the very beginning, we've been morselizing the bone and putting it back in.
I think when you do the vertex wide vertex with the lateral wedge releases, the helmet isn't as important as if you just do the minimally the sort of narrow vertex strip only. Then I think the helmet's more important. So those are some of the compromises you're talking about on one of your earlier slides with the arrows going left and right.
Yep.
great. That was a very, very helpful discussion. I'll add in terms of having a colleague in craniofacial surgery. We're lucky here to have excellent craniofacial surgeon and Dr. Wilswinkle. He'll talk in just a few minutes. But I will say my previous institution, I'll say our craniofacial surgeon was not nearly as excited about these cases as possible as we have, as Eric is, and other people I've worked with. So the ability to be able to do some of these endoscopic cases on your own without having to drag someone who doesn't want to be there in there is a great thing, especially, as our fellows all go out into different types of practices. It allows you to continue to take care for these patients, at least a certain subset of these patients, without a very complex craniofacial program, at least initially. And it could be a good building block for the future. And so with that, I am going to move on to our next presenter, Lauren Schultz, who is a PGY4 at Ohio State.
Yep. All right, let me share my screen. All right, so thank you everyone for having me here today. I'm going to do a case presentation on a lambdoid synostosis kid who had Chiari with their presentation. So this was a 9-month-old female who was previously treated at outside hospital, and she was diagnosed with right-sided positional plagiocephaly. They attempted helmet therapy for several months, and that was not successful. So she then presented to us for a second opinion. She underwent a low-dose head CT, which did confirm that she had unilateral right lambdoid synostosis and partial right squamosal synostosis. We had a limited MRI done as well that showed that she had a Chiari-1 malformation with mostly right-sided cerebellar ectopy measuring 14 millimeters. She did not have a syrinx. She did not have hydrocephalus. Her ventricles were enlarged, but no hydrocephalus. And as far as we could tell, she did not appear symptomatic from this. So at 10 months old, she underwent surgery. She was offered a single stage open posterior cranial vault reconstruction with concurrent Chiari-1 decompression bone only. Unfortunately, Nationwide just recently implemented a policy where we are not allowed to take pictures in the OR at all under any circumstances. So I don't have any photos from the surgery, and there was no photos from pre or post-op, but this is a post-op low-dose CT, again, obtained for unrelated reasons. She came to the ER for a different complaint and was scanned there, but it at least gives you an idea of the procedure she underwent. The plastic surgery performed the flip craniotomy, so there was a vertex barrel stave and then a barrel cut, and then they flipped that backwards and we did a right parietal occipital craniotomy, flipped it 180, and essentially reversed those two. She did very well after surgery. There were no complications. So the point that I wanted to visit for this case is the Chiari decompression warranted? We did it. In the literature, there's conflicting evidence for this. So there are many papers out there that advocate for posterior vault distraction alone and performing that first. For example, there's a paper from Strahl in 2011. It's a retrospective review, and in the paper, they talk about that there were 7 patients who had craniosynostosis and Chiari malformation who underwent vault repair alone, and then post-op had decrease in their Chiari cerebellar ectopia and improved CSF flow studies without any intervention. On the flip side, there's some evidence in the literature for performing a Chiari decompression in conjunction with your posterior vault surgery. So there's another paper that we found from Pearson et al. It's a plastic surgery journal in 2016. They had 17 children with craniosynostosis and Chiari that they treated with single stage repair and suboccipital decompression. And of those, none of them required reoperation or showed any progression of their cerebellar herniation and post-op scans. They had 2 craniosynostosis patients who underwent repair alone, who then later went on to develop symptomatic Chiaris, which did require decompression. And flipping back to the Strahl paper, reading it further, I saw that there were 12 patients in her cohort who developed Chiari malformation after their vault repair. And 5 of those were de novo, meaning they had no evidence of Chiari before. So I think that kind of raises the question of, is this something where you would advocate doing the posterior vault alone and then kind of waiting and watching? Or in cases like this, would you argue just doing everything up front on the basis of this patient possibly developing a Chiari post-op and requiring a second surgery? And if you were to advocate for that, would you consider the degree of cerebellar ectopy in your argument or not?
Thank you, Lauren. Thoughts about this? I'm going to give as much time for people to volunteer before I'm looking at Joseph Falcone. What are your thoughts on should treat Chiari specifically lambda?
Yeah, I think the cases that you presented, those case reports, are very interesting. How much change there was, especially the ones where they had de novo Chiaris that developed afterwards when they didn't have it before. But it seemed like a significant number of the patients that had a Chiari before had improvement just with the cranial vault reconstruction. So it seems to make sense in my mind to do the smaller procedure and see what happens. And then if they develop a Chiari, especially if it's symptomatic later on, to address that when it becomes manifest.
Anyone have any contradictory thoughts to that? We should just be addressing all of these Chiaris when we see them?
I was just texting with Amy Lee about how many different ways there are to attack the same problem. And there's so many different variations in craniofacial surgery of what people do and what their plastic surgeons do. And the Chiari question is really interesting because in posterior distraction, a lot of people will argue to take the cuts down all the way to the foramen magnum and decompress. And then there's a group that said you just have to like make the posterior fossa bigger and you don't have to go all the way down to the bottom. And, you know, both sides have evidence that the Chiari gets better no matter what you do with posterior vault distraction. So these are really interesting questions because they're sort of real world questions. And I was asking Amy about her pictures, her intraoperative pictures. She has the pericranium on and is making the bone cuts over top the pericranium, where a lot of craniofacial surgeons will take the pericranium down with the bone, with the scalp flap. So it's one of the great things about these types of surgeries is as you go and operate with different plastic surgeons, they have different ways of doing things that you learn from. And so, you know, there's a zillion techniques to do these surgeries. So I think this is just evidence of that.
Absolutely, Susan, thank you. And that's actually a perfect segue to Dr. Eric Wolfswinkel, who is our craniofacial plastic surgeon here. I will say, you know, just as you were saying, Susan, I have learned a lot of new techniques from him, things that I didn't do or did the opposite in previous places. And so it really is amazing to have the experience of our plastic surgeons help to guide the way we treat these patients.
Well, thank you guys so much for including me in this as a plastic surgeon and non-neurosurgeon. I learned a lot from Dr. Durham in the past, so I thank her because I worked with her during fellowship. Posterior distraction is kind of an evolving technique that has been used more and more over the last approximately 15 to 20 years in craniofacial surgery. And it gives you options. Let's see if you guys can see my slides. For treating different disease processes, including Chiari, because that is one of the things that they do say it's very beneficial for. Do you guys see my preventer view, or do you see the actual slide?
We see the slides.
Okay, sweet. But where it's really become beneficial is actually in syndromic craniosynostosis. So this is a 2-week-old that had a syndromic diagnosis. Mom had the same diagnosis, but a more severe form. So we asked our residents to do an examination of them, which included chucking the skull. And I include this because not everybody knows what I mean by chucking the skull, but basically, you can feel the suture is moving versus this is a bicoronal where the suture is fused. Sorry for the background noise, but when they're young and in the ICU or in the neonatal, you can actually do that to their skull, through the skull, and see it actually move. And that will tell you whether the sutures are opened or fused. So that's a good clinical examination that you can use to see that, in addition to the change in head shape, because you should be able to diagnose about 95% of kids just on clinical exam alone. I will tell you that some SAGs can be misleading sometimes. And so I do still get a CT scan to confirm the diagnosis. But this was a 3-month-old with Cruzon syndrome, which Dr. Lee talked about earlier. So midface hypoplasia, proptosis, bicoronal synostosis associated with fibroblastic growth factor receptor 2. And this one did have papilledema on eye exam. So in order to treat that, we want to do an earlier procedure. One of the major options for bicoronal synostosis is usually a frontal orbital advancement. The issue with that is that typically you have to wait for them to be a minimum about 7 to 8 months of age for the bone to be thick enough to be able to reshape that frontal bando to hold its new position, but also malleable enough to where you can actually do those bends in the bone. So when we go off to the back table and we're doing all those bendings, usually the kind of sweet spot for that is somewhere between 7 to 10 months of age. So you don't want to do it in a 3-month-old. And so the techniques to basically expand the posterior vault have been performed. And there's just expansion, which you can do directly, which requires a lot more dissection and a lot more plating and a lot more time. Whereas a posterior vault dissection is, or posterior vault distraction can be just the craniotomy cut without a lot of dissection. You put the devices in, and then you do the posterior vault distraction, which allows for increased intracranial space, which then buys you time to delay the patient until they get to their frontal orbital advancement or whatever other craniofacial procedure that they may need. So similar to Dr. Lee and what she described, we look at craniosynostosis with increased intracranial pressure and concerns for that. Single suture, much less common, but in multi-suture, it's somewhere between 40 to 50% and increased in syndromic kids. And often they have increased intracranial pressure early, as did this kid with papilledema seen on dilated eye exam. There's also aesthetic concerns and social impacts that they can have. So by including us into the surgery and allowing us to do some of the reshaping and remodeling to try to restore a more aesthetic head shape, that allows them to have less psychosocial concerns. These are all the kind of options that we talk about for types of craniosynostosis. I apologize for the busy slide, but we've talked about endoscopic strips. There are a lot of teams that use spring-mediated cranial vault expansions for all different types of sutures, and you can kind of use that in different directions. I personally don't use that with Dr. Selden and myself here don't do that. But I think it's a valid technique, and our partners across the street at Randall's do use those. There are open procedures, not typically, or that are done later. Frontal orbital advancements, what we talked about, and then again, posterior vault expansion versus distraction. So we're going to focus mostly on the distraction osteogenesis or traction osteogenesis, because you're really pulling the bones apart. It does require 2 surgeries, and in this case, we're using it for the posterior vault expansion to help, again, kind of buy time until that we can do their frontal orbital advancement. So distraction osteogenesis was originally described in the, I would say the originally was described to lengthen the axial skeletons by Elizaroff, and then in the 1992 it was used by McCarthy in the mandible, and then 1998 when it was they actually used it for the cranial skeleton. And so there's a couple stages. So you'll hear us talking about kind of the 4 major stages of distraction, and one is just the osteotomy and placing the devices. Then we usually wait a couple days to allow the bone to start that initial healing, and then there's an activation phase, which is somewhere between 3 to 4 weeks. It's usually closer to about 15 days, depending on the type of distraction you do. But there's a bunch of different protocols that are used across the country with no real consensus on what's better. We do 1.8 millimeters a day, and we do it BID just because we don't want the nurses to do it more than once, and it limits complications that way. And then there's a consolidation phase where we actually let that bone heal for about a 2-month period, and then we come back in a separate surgery and remove them. So this is that same patient with her vault distractors in there. This is the, we use 2 for the posterior vault with an osteotomy that goes down pretty low, not all the way to the foramen magnum, but relatively low. A lot of the literature comes out of CHOP, so I have to give credit where credit due, because they do a lot on publishing about the safety, the complications, and the amount of volume expansion that can be achieved in posterior vault distraction. And it has shown to have a greater increase in intracranial volume as compared to frontal orbital advancement or just posterior volume, posterior vault expansion alone with plating. And they have a recent patient paper about how low should we go. And they did show that there's about equivalent safety for it. And then they go below the torcula, which is a constant conversation about how low should we go, and in doing that, and then are you decompressing for Chiari and those kinds of things, depending on what you're doing. Here we typically actually just do whatever vault expansion that we're planning and see if the Chiari resolves or not, and then come back for Chiari decompression later. Again, this bought us time until we did our frontal orbital advancement. And now she's about 15 months of age here and doing well. You can see, obviously, they have other issues with their midface hypoplasia requiring a trach because of obstruction. Dr. Lee gave a good overview of Cruzon, so I won't go into that. But the key to these is there's no hand abnormalities in Cruzons compared to some of the other diseases. This is our kind of protocol in terms of how we treat craniofacial dysostosis. This is from Dr. Urata, who I learned all of my techniques from with Dr. Durham. And so this is kind of his thought pattern on how to treat them. So this was a patient that had severe brachy and turricephaly and had increased intracranial pressure. So we did a posterior vault distraction, and then later came back for the FOA closer to 7 months of age. Happy to talk about any of those things. This is my email and cell phone number for all of the fellows or residents that are on. I'm happy to discuss craniosynostosis or any other craniofacial thing at any time. So please feel free to reach out if you have any questions.
I just have a quick question. That was a great presentation. It's awesome. For the patients that have had, elevated intracranial pressure initially, and maybe any of those who had any degree of ventriculomegaly, was there any discussion of managing, the potential hydrocephalus up front? Have you had any patients where you had to manage the hydrocephalus like up front? Or do you pretty much routinely perform the cranial expansion and hope that'll resolve the concern for elevated intracranial pressure?
Yeah, so obviously some of it depends on how bad the hydrocephalus is, if they've developed that. And so a lot of these kids, especially the syndromic kids, ultimately will end up with a shunt at some point throughout their process. Some of the other, not Cruzon's less so, but some of the other disease processes end up with more shunts, I would say. But we try to, again, because we can do that posterior vault expansion relatively young. And so we try to get as much accomplished with that early on. And then again, see kind of what results. And then we can add in those different treatment algorithms as needed, depending on what shows up.
Thank you.
Yeah, I think, Jonathan, if you sometimes don't treat the hydrocephalus so up front, the bone is actually not going to heal. So even if you are to do the posterior distraction, like some of those severe cases, I think we do have to put the shunt in up front. Richard Hopper really talks about this kind of bone pressure wave a lot. And so, yeah, if you don't, you kind of have to have that right balance where we try to wait, but then if you actually do the skull surgery, but they've got underlying hydrocephalus, then the bone doesn't actually heal. So kind of finding the right timing to do that.
So I'd love to, this is Toba, I'd love to throw a question out there. Would anybody do an ETV in these kids, these syndromic kids, if there was the possibility to do so? I know we've done that several times here in Miami and have been successful in doing so and avoiding a shunt. I'd love to hear everybody's thoughts about that.
Yes,
We have. Yes,
absolutely.
for sure. Yeah, I know Governor Alley and I are on the same page. Definitely.
I have
100%. If you can do ETV, CPC, I would do it for multiple different reasons. One, just trying to keep shunt hardware as not as a complicating factor in doing craniofacial repairs. It is really challenging to do and figure out logistically how to perform a craniofacial repair when there's already shunt hardware in place if you didn't get a chance to do the ETV, CPC beforehand. So I think, yes, that's a great question. And I think a lot of people are shaking their head. Yes, we'd agree. ETV, CPC can be a great, treatment modality for this patient population.
Yeah, it's really helpful for us also because we come back at 6 or 7 years of age and we're doing a large cranial vault or cranial reconstruction. And then we're, exposing your shunt and doing all of that. And then you guys aren't very excited about that component when we're in the mouth and next to your shunt. So if you can avoid the shunt hardware, I think it's great. But a lot of times it is necessary, as Dr. Lee said, because depending on how bad they are initially, it determines whether they need it.
I also worry about, with a shunt in place, especially if it's one which doesn't have a programmable valve, you then have to worry about, supraphysiologic cerebral spinal fluid drainage that can then negate some of the craniofacial repair. You can get recession. And I would just worry that shunts, drain, excessive amounts of cerebral spinal fluid. And based upon Dr. Lee's, presentation, which you showed in that earlier slide, so much of cranial growth is reliant upon, brain and dural expansion. I worry that shunts are going to negate that process.
And just to add to that, and this, I'm thinking, Eric, of that kid we had recently who, developed essentially secondary synostosis as a result of over shunting early in life. And having the shunt in place made it impossible to do the distractors just because it was like we'd have to completely remove the shunt in order to do the distractors, and ended up with a bigger, vault expansion. And Eric can speak a little bit to that. So I know I'm veering off the topic of synostosis into hydrocephalus, but to definitely consider the ETV as an option up front is a good thing to do.
And I'll put a plug in for the occipital approach for the shunt in a craniosynostosis patient, because yes, it's in the way, but it's less in the way than a frontal shunt. And if he does a monoblock later, it's not going to be in his field at all, which is helpful because he's in the mouth half the time when he's doing a monoblock. So just the plug for occipital approach in these patients. And, you know, usually the syndromics are bicoronal, so you'll be able to stay away from it for most of what you need to do. And it's harder to do the posterior vault distraction with the occipital shunt in place, but you can do it with the right patient, the right pre-op planning. But it's definitely a challenge. The occipital shunt also gives you more catheter in the ventricle. So as you distract it, you're not going to pull it out of the ventricle either.
I'm with you, Lance. I similarly do the same thing.
Yeah, very good point, Lance. I always try to avoid frontal shunts on any synostosis kid for that exact reason. And I'll use navigation to get as low as possible. I'll go lower than I typically would just to keep it low and out of the way.
Yep.
Any other discussion points, questions, thoughts? This has been a really wonderful discussion. I want to thank Amy and Kelsey and Lauren and Eric and everyone who's here and contributed. You know, these and the section leaders for putting together this wonderful series. I think this. I wish this had existed when I was a fellow, but very proud to be able to continue it on for all of pediatric neurosurgery in the future.
Yeah, thank you, Jesse. Thanks, everybody.
Thanks, everybody. Great talks. Great
Right.
cases.
Thank you. Thank you for contributing.